Great. Hi, I'm Dr. Rushika Fernandopulle. I'm the CEO and co-founder of a small company called Iora Health. Can you all hear me? Yeah. Well, good morning. It's great to be here. So it's hard to follow Kavita, good friend. But I want to talk to you a little bit about primary care payment. I know there's a lot of talking in the rest of this session about what is primary care and where ought it to go, but I think very foundational to it is payment. So I'm a primary care doc, and about 12 years ago really set out upon a journey to figure out how do we actually build a new model. And I, like Kavita, found myself, like many of you probably, at the end of a long day. It was February in Boston, and where it got dark at about 3:30, it seemed like, and I had a day of seeing patients in 7 to 10 minute aliquots, I love that word, and barely getting by, and we had a new EMR that was put in, and so couldn't finish the notes, had to jot stuff down as quick, kind of pad of paper, and then was staying 3 hours after work trying to actually put this stuff to get my 99213 or 99214 ideally, and was sitting there and had barely eaten lunch, had barely gone to the bathroom, and a colleague was doing the same thing, looked at me and she said something very profound, and she said, "Every day I lose a little piece of my soul." We went into this because we wanted to help people, and we got all this training and spent all this time, and these people come to us with such incredible needs, and we could help them, but we can't. And not because of bad people or bad intentions, but because the system simply doesn't let us do it. And that's when I decided that all this, and I think we all know that, but all the attempts we've tried to make to fix primary care are small and incremental. Getting certified level 3 medical home and ACOs and quality management and all sorts of names we've used. And the simple insight was maybe we ought to start over and figure out fundamentally what's wrong. And I think the problem, the reason why this incremental stuff doesn't work is that fundamentally there's a big problem with where we've gotten into primary care. Actually, I'd argue in healthcare in general, is we have turned healthcare in general, and primary care in particular, into a series of transactions. Right? Everything's a transaction. You see a patient, it's a doctor sick visit, you document, code, and bill, you fill out all these little check boxes and how many reviews of systems and complexity, and then you submit a bill, and then they either, Last I checked, transactions have never healed anyone, right? It gets in the way. The thing that heals people is relationship. We know that. And if we want to really be able to focus on relationship, we have to take the transactions away, right? And what is really enforcing the transactions is the payment model. It's a fee-for-service payment model. And so really the primary thing is, point one, is trying to change primary care and innovate it in the absence of payment redesign is a waste of time, period. It's a waste of time, right? So all this medical home stuff where you use the same payment model is a waste of time. And number two is I think any sort of way to change it that builds on fee-for-service is a waste of time, because what it does is it keeps the transactions going. So all the stuff, Medicare in all its wisdom, all these APMs are all built on fee-for-service. You're still billing and coding, and yeah, we'll give you a little bit of scraps at the top of it. But if we don't get rid of the fee-for-service, we're going to be stuck in this transactional model. So we decided to start off and say, let's actually create a different sort of care model. And really, I think there are sort of three pieces to this sort of different payment model. The first one, really simple, is get rid of fee-for-service, right? This is about a relationship. You don't pay for relationships by thing you do. Inherent in the fee-for-service that someone else is telling us what is valued and what is not. I will value a doctor sick visit and not an email and not a visit from a health coach. It is our business how we meet people's needs. It is not up to anyone else because we know the patient. So we build all of our payment on a very simple global payment model, is pay us a fixed fee to take care of these primary care folks and let us get on with it, right? No coding, no billing. The simplest way to do that is a primary care capitation rate, a sort of risk-adjusted primary care capitation rate, or direct primary care is another way people frame it, is pay us X amount for the patient and let us get on with it, right? So our billing in these systems is very simple. We send a one-line, so we build practices. What we've been doing is saying, let's build a new model, right, based on a fixed fee. So how do you do that? What we do is we actually go to payers. self-insured employer. We started with self-insured employers and union trusts. We've since then moved on to working with some health plans and Medicare Advantage, some health plans with exchanges. The simple proposition is, it's funny how in every other industry, the people who sell the service determine how they want to get paid, and they ask the customers, do you want that or not? I'm in a restaurant, going over a buffet, we have a buffet, and you say, can I order it a la carte? You say no. Oh, we got it, good. So we say no. And so we said, let's actually just simply do that. So now there's slides, I'll go back a couple. This is what primary care ought to be, right? The doctor, it's one of my favorite paintings. You notice the doctor gazing in on the child, the ward patient's back. That's why I went to primary care. This is healing relationship. This is unfortunately what primary care looks too much like today. It's a great drawing from JAMA, I'm sure some of you have seen it, of a drawing of a kid with a mom in the office and the doctor on the side trying to meet his meaningful use by typing on the keyboard, right? This is what transactions do to you, and we need to stop, right? So what we've done is we built Iora Health, and we said, let's actually just say that paying fee-for-service is the wrong way to pay for primary care, and so all we will take is not fee-for-service. And if you're willing to do that, we will work with you, period, and build practice. We have 29 practices now around the country in 11 different cities. By the way, we're opening in Miami soon. I'll put a plug in. Anyone who wants to come work with us in Miami, we are looking for new people. But really, by getting this fixed fee payment, we can change the nature of our job, right? Our job is no longer see one patient at a time and do the best job we can. That's not the job I want to do. Our job is we have a population of people, they're our problem. How do we improve their health and keep them out of trouble? That's the job that I want to do. It's the job society wants us to do it with. And when you start doing that, and by the way, we only do that. I think what a lot of other people are doing is they may get a little bit of funky payment, but they're doing it while they're also trying to do fee-for-service. It's really hard to do both at the same time. So we've simply said, fee-for-service is the wrong way to do it. Stop doing it. Just do it this way. Let's build a vision of where we want to go. So what you do when you do this, you can able to do a lot of things. Number one, you can build a really robust team, right? You no longer say you will only get paid for doctor visits and not anyone else. So we hire these people we call health coaches who are from the community, speak the language of the people they serve. We have 3 or 4 of them per doctor. It's a lot. We have nurses, we have social workers, we've got exercise folks. And we get paid for all of them, right? We do things like we can sit in a huddle every morning and we talk about our patients. Not a 5-minute huddle, by the way, like most medical homes do, a 45-minute huddle. And we don't talk about the people coming in. Who cares? They're coming in. We get to talk about the people who are not coming in, who are getting into trouble, so we can reach out to do something about them. We can do about 60 or 70% of our interactions non-visit based. We think it's really important we meet people at least once, because that builds a different nature of relationship. But after that, we can do almost all the things we do by video, by telephone. It's 2016, for God's sake. We could be spending time reaching out to people proactively instead of being reactive. We can do lots of groups, right? Groups are a great way to get patients to learn about their chronic condition. This is a yoga class we did in Prospect Park in Brooklyn. So again, you can just be really creative about how you meet people's needs. You can also, maybe more importantly, let teams feel like your job is to improve people's health and do whatever it takes, right? So grocery shopping. So we have many of our health coaches have found with folks with diabetes, et cetera, the best thing to do is to go take some grocery shopping. Let's walk around, pick up what you typically buy. Now let's sit and look at the labels. Why is this a bad idea if you're diabetic? Now let's go to your grocery store and find something in your store that serves that need, but is that better for you? And go home and try it and see what it is, right? People say that's inefficient. 1 hour of going shopping with people can change habits for a lifetime. We have lots of other great stories. This is a great story about, in Seattle, we have a practice for Medicare patients. We have a lady, 72 or so, about 3 months ago, who had grown up and lived in Sacramento. Her husband died. Her daughter, who lived in Seattle in the suburbs, said, "Mom, I don't like you living alone. Sell your house and come move in with us." So she did. And of course, this poor lady is now stuck in the suburbs in her daughter's house, doesn't want to burden her daughter for a ride, so is getting more and more depressed and isolated. And so her diabetes, hypertension were out of control, came into the practice. Our health coach realized the problem here isn't that she needs more medication. The problem is she's isolated. So we run a group, one of our many groups the social worker runs, called It's My Story, where we get patients to get together and just tell their story to each other. Really simple, but hugely valuable. I said, well, but she can't get there. Well, we also do a pilot with Uber. We can actually, through our EMR, send an Uber out to get people and bring them back, right? Stop making excuses, just fix the problem. But she's actually more important than that. Let's actually teach her to ride the bus. So the health coach rode the bus out to her house, showed her how to do it, got her a bus card, rode the bus back to the clinic, went to the group, met some neat people. On the way back, said, okay, you ride it back home alone, but I'm right here on my cell phone. You call me if you have any problems. And the patient loved it. And she now comes to the group by bus. More importantly, takes the bus to go meet the people she met at the group for coffee on other days. Guess what? Her diabetes and her hypertension are better. This has nothing to do with healthcare. This is what primary care ought to be, right? Fix people's problems. And when you get a global payment, you can do that. By the way, one of the big problems, if you look at US healthcare versus Europe, why do we have sort of higher costs and poorer outcomes, is they spend 2 times as much on social services as healthcare. We flip that twice. I'm tired of trying to lobby for it. What we say is sort of give us the money, and we will reallocate healthcare spending to social services. So point 1, fee-for-service, block payment, no 99213 garbage. Number 2 is, Kavita mentioned this, double the amount going into primary care. Primary care is 5 to 6% of healthcare spend. Wherever you look at it, that is ridiculous. It means that 95% of what we spend money on is failure of primary care. So we sort of insist on double down on the primary care, right? And you can start off by trying to get the visionaries to just do it. And by the way, the promise isn't, we cannot increase total healthcare spend, right? No one is going to tolerate that. The proposition is by doing primary care better, you lower downstream spend, keep people out of the hospital, out of the ER. So does this work? Barbara has a lot of sort of correlations on that, but we've been doing this for a while. It absolutely works. Here are 4 of our practices over time. Boeing employees, Atlantic City, casino workers, Culinary Extra hotel workers in Las Vegas, and then Medicare practices, which are Seattle and Phoenix. And you look at that number there, hospital days going down, roughly 40% drop in hospital days relative to well-matched controls done by independent academics. 40%, 40. Total healthcare costs down 15 to 20%, right? So you pay for this extra 5% of primary care really easily and have a bunch left over. So you could start by actually trying to get a visionary. What we do now is we say, I don't want to convince anyone of anything, just give us total healthcare costs. Global payment, we'll spend it on the primary care, and the stuff that's left over we get to keep and spend it more in primary care. And by the way, this is done not by skimping on care, but better outcomes. So better experience, better engagement, better diabetes control, better hypertension control. I too hate those measures, by the way. They're the wrong ways to measure primary care. We're just starting to work on sort of better ways that look at coordination and meeting people's needs and the like. The third piece, by the way, so if it's no fee for service, double down on primary care. The third piece is get rid of the financial barriers at the point of care, right? These co-pays for primary care are ridiculous. What do co-pays do? They dissuade people from doing things. Why exactly we are trying to do that with primary care, right? It's cheap and it's actually effective. This is Rand Health Insurance Experiment, right, from back in the 1980s, which showed, as all of you know, that when you put cost sharing on people, particularly low-income people, they do not only the unnecessary but the necessary stuff. So again, what else does it do? When you free yourself from fee-for-service, you can get rid of these stupid EHRs, right, which are fancy billing systems that enforce the 99214s and get in the way. So we built our own, and it's so liberating not to have to deal with the coding and billing. And the other one is really joy in practice, right? The fourth aim, which we all really need to talk about, is when you're freed from thinking you're a widget online, you can have a very different outlook on life, and our teams are happier, far happier, measured in a variety of ways. So to close with a quote, my favorite quotes from the great sculptor Michelangelo. They asked him, how do you get the Pieta, this beautiful sculpture? And he said, it's really simple. He said, take a block of stone, and I chip away everything that's not the Pieta. And it emerges, right? Too much of what we're trying to do, everything that Medicare is trying to do, is adding on to this block of stone that's crappy healthcare. And what we need to do if we want to be successful is actually take stuff away. And I think one of those things really is sort of fee-for-service if we really want to go where we want to go in primary care. So thank you.